So, hello everyone, and welcome to our second Research Discovery Seminar Series session. I'm Shahrazad, a PhD student at Université Laval, and I will be moderating the session along with Gabrielle today. You can
Yeah,
introduce yourself.
yeah. Hi, everyone. My name is Gabrielle. I'm also a PhD student at the University of Calgary here, and I really look forward to having our brachytherapy session today.
Great. So the topic is innovation in brachytherapy. We'll be highlighting automated, precise, and targeted treatment. We are happy to host great speakers who have kindly accepted our invitation. Dr. Christopher Duerrbeck, Prarthana, Pasricha, and Ruiyan. Thank you all. Uh, so our agenda includes few minutes of opener remarks. Then we start the presentations, each followed by 5 minutes of questions, and we end up with the closing remarks. During the talks, please mute your mic and either raise your hand or write your questions in the chat. We will be reading that later. So for the new ones who doesn't know us, we are part of the Comp Student Council, and we provide initiatives that communicate with the students in medical physics, either through professionals like in the Comp Career Catalyst seminar series, or with students to students like the Research Discovery seminars. We also have our great social media team putting together all information of interest available to students. And of course, the ambassadors serving as our connections, the main connection between us and the students in all Canadian universities. We also organize student sessions in the annual comp meeting, like Young Professional Workshop, Canadian Residency Fair, Science Spoke Consistently, and so on. And this year, that will be in collaboration with the AAPM Student Council during the joint annual meeting in Vancouver. More precisely, the RD Sessions is a research development initiative for grad students and residents in medical physics, where you can share your discoveries, inspire peers across Canada, network, and build collaborations. And of course, you can add invited speaker to your CV at an official Com Student Council event. So if you are interested in participating in our next sessions, just scan the QR code and send us a short description of your research. Sweet. So now I'm happy to welcome Dr. Christopher Duerrbeck, a postdoc at University of Erlangen in Germany, and whose talk will be on accuracy beyond sight, electromagnetic tracking in interstitial brachytherapy. The floor is yours, Christopher.
So, can you see my screen? Perfect.
Yes.
So, thanks a lot for this kind introduction. My name is Christopher Duerrbeck, and as it was already pointed out, I'm German. So you might think, what does this guy have to do with the comp? Quickly on that, so I spent a few months in 2022 in Quebec with the group of Professor Luc Beaulieu, and that's where the connection comes from, because we were doing a similar project. And yeah, that's how we met. I want to talk today about accuracy beyond sight electromagnetic tracking in interstitial brachytherapy, which is a technical solution to some of the problems that brachytherapy has, but I will go into that now. First of all, I would like to disclose that this project was part of a collaboration agreement with Elekta Brachytherapy. So the afterloaded devices and some of the applicators will have the shape of the Elekta ones, but obviously the basic principle can be applied to any of these afterloaders. The basics, well, you probably all know radiation therapy, but just to go back to the basics, we have teletherapy and brachytherapy, which are basically opposites because teletherapy is external beam radiation therapy, where generally you have a source that is located outside of the patient. And in brachytherapy, which is already included in the name because brachy actually means from short distance, we have internal radiation therapy because we apply radioactive sources. We move them, navigate them into the patient's body to radiate the target from there. Now, from a device perspective, obviously teletherapy is usually applied with a linear accelerator. I'm not talking about particle therapy here, just the basic photon EBRT. Whereas in brachytherapy, we use afterloaders that have radioactive sources about the size of a grain of rice that is attached to a cable that will then be introduced into the patient through an applicator. Now, what is the advantage of brachytherapy? The big advantage is that it's highly accurate because it has a steep dose gradient. So we can much better spare healthy tissue, therefore reduce toxicity. And at the same time, we can administer higher doses than we would be able to with EBRT. Now, the problem here is because it is so precise and because we have that steep dose gradient, we must be very accurate because every millimeter counts. Because if we don't hit the target right, we will be off and we will instead irradiate healthy tissue and miss the tumor, at least partly. So what we need is quality assurance. And when you think about EBRT again, because this is much more widespread, you have things like, for example, CBCT imaging at a LINAC. So there is no LINAC today that doesn't also have a cone beam CT device. We use it for geometric verification, meaning patient positioning, in order to not miss the tumor. At the same time, we have the requirement to quality assure our treatment plan, and there are various ways to do that, and one of them is phantom measurements. So there are various distributors of phantoms that we can use to measure the dose distribution. And that's a requirement before applying the treatment plan to a real patient. Lastly, there's also what we call portal imaging. So using an electronic portal imaging device that captures the transient dose behind the patient, which can then again be used to recalculate if the treatment plan was correctly applied. And the overarching goal of that is to detect discrepancies and errors to mitigate the effects of those. Now, when you go through all these three and think about what is available in your brachytherapy suite, you might find out that there's actually not that much. So we don't have cone beam CT imaging in brachytherapy, at least not, well, it's not that widespread. So there are a few, there's a mobile cone beam CT being developed at the moment, and some centers already have that, but it's not a standard. Phantom measurements, same thing. So basically, what quality assurance wise, there's only machine QA. So you check the afterloader, you check the source cable, you check the dwell times, but there's no patient-specific quality assurance that is dedicated to a single personalized plan. And lastly, portal imaging, again, there are detectors that some centers use to do some kind of in vivo dosimetry, but it's again not part of clinical routine. So that was kind of the situation when I started my PhD. And the idea was, how can we improve on that? So the challenges to sum up are that we have limited in-room imaging capabilities in brachytherapy treatment suites. There's no systematic patient-specific treatment verification. And the question is, how can we detect errors if we don't do treatment verification? Lastly, this is a more special to breast brachytherapy, which was my focus. is, does the implant change over time? So usually brachytherapy treatments are quite short, so within 2 to 3 days, but those accelerated partial press irradiations that I dealt with, they usually take 4 to 5 days, and we also tried to answer the question if these implants change. Now, when I started, I found out about this, and then we asked ourselves what could possibly go wrong at all. And that brings us to errors and uncertainties in brachytherapy. And it sounds a bit mundane, maybe, but one of the simplest errors that keeps occurring is catheter swaps, because you have to connect the afterloader to transfer tubes and the transfer tubes to the implant that is surgically implanted into the patient. And while doing so, it can just occur that the RTTs mix up some of them, or that the catheters are mislabeled, leading to errors because the radiation source does not enter the catheter it's meant to enter. Therefore, it alters the dose distribution, and we might end up with overdosage or underdosage in certain areas. Another error is catheter shifts, because as I pointed out, the implant is fixed, but obviously those catheters are not sewed to the patient, so they can move in longitudinal direction. So what we encountered is that some of those catheters actually stick out on one end, also altering the position relative to the target volume. Therefore, we also end up with a different dose distribution. And lastly, we also have anatomical changes, because this procedure is quite invasive. I mean, the catheters are not that thick, about 2 millimeters usually, but still, as you can see in the image here, some of the patients react quite a lot to that, and they show edema or even strong hematoma. And the swelling inside the breast is well, not well studied. So we figured, also looking back at the literature that there already was, that human hairs are the most common cause of critical incidents in brachytherapy, at least partly. And now to eradicate this aspect of human failure, we thought, why is there no technical solution for that problem? And that was the rationale of my project, because we tried to introduce electromagnetic tracking, which is a technology that is already available in various surgical procedures, and tried to transfer it to brachytherapy. We also call electromagnetic tracking the GPS of brachytherapy. And that is actually what I explained to the patients that were included in the study that I co-supervised. I always told them that they should imagine this system as a GPS system for a sensor that travels through the catheters in their breast. And the big advantage of electromagnetic tracking is that it can assess the implant geometry dose-free and in real time on the treatment couch, so inpatient treatment position and prior to every fraction. And this is something that no other technology is able to provide. And the even better thing is that in this project, this technology was integrated into a clinical afterloader. And we called that the hybrid treatment delivery system, because we were able to keep up the usual workflows, just with the addition of this electromagnetic tracking sensor that was integrated into the check cable. So just as a reminder, the check cable is the cable that runs through the implant in order to check if it can travel safely to the distal end, so that there are no kinks or anything in the catheters, no obstructions. So that is actually a step that is mandatory. And we figured that it would be perfect if we could use that mandatory step to acquire additional information about the implant. Now, this is a sketch of the setup. So you can see a computer for data acquisition. You can see the clinical afterloader connected to the implant. And this gray box hovering above the breast is the so-called field generator that generates an electromagnetic field that is the basis for the localization of the sensor within the body. Now, this is an image of the actual clinical setup. And yeah, you can see there are quite a lot of transfer tubes and cables around. And when we start a measurement, it looks like that. So this is an animation of actual data. And you can see this stop and go like motion of the sensor that is traveling through the catheters. These dwell positions, sensor dwell positions, not like source dwell positions, are spaced 1 centimeter apart. And like this, we try to cover the whole implant. Now, once this is done, we get a 3D representation of the catheter implant, just like we would with CT-based implant reconstruction for treatment planning. Now, we can use this EMT-assessed implant geometry for various purposes now. And first of all, we can save quite a lot of time because this implant reconstruction, so the clinical step that you would perform based on a CT for treatment planning, takes quite a lot of time, at least in breast brachytherapy, because we usually have between 15 and 25 catheters. And for each of them, you require 2 to 3 minutes to reconstruct them. So you end up with 45 to 60 minutes for very large implants, even more than that. And that's really time that you could save doing that automatically with this system. And that's what we did. You can see a snapshot of the treatment planning system that we used and the reconstruction points that were completely based on this EMT system. And to the left, you see this box plot where we found out that the deviations that we got from the automatic system aligned very well with what an experienced human user who reconstructs the implant would achieve. In fact, we were actually better than the inter-observer variability between 2 experienced medical physicists. So that shows us that the system is accurate enough and we can automate that step. The next thing would be detection of treatment errors prior to treatment. And that's a good thing. We can spot those errors before applying the treatment, which is a big benefit, especially over in vivo dosimetry, where you have to apply the treatment and then find the error while the treatment is already running. Instead, we can find them before we actually start the treatment. And here I brought another example by a colleague of mine from Rotterdam. And he didn't deal with breast brachytherapy, but prostate brachytherapy. And what he found is that quite a lot of prostate implants they looked at showed large errors in the reconstruction because, as you might know, prostate brachytherapy relies on ultrasound imaging, and those white spots that you try to identify as the needles can sometimes change or move around, or some needles shadow others, and then you cannot be 100% sure which reflex is the one that you're looking for. So by circumventing that with the EMT-based reconstruction, they found that some of the needles actually showed deviations of more than 1 centimeter. So those are quite major deviations that lead to large changes in the dose distribution that would have gone completely unseen if not for the EMT system. So this is just to raise a bit of awareness and also point out that this EMT system can be used with any brachytherapy entity. A current project of mine is actually the prevention of patient mix-ups. So patient validation is a big thing here, well, coming up in the recent months in the European Union. So there's actually legislation requiring that for every LINAC, and it's also going to come up for brachytherapy. So I figured, why not use the implant geometry that we assess with the EMT system? Why not use it as let's say, a physical ID card that is also temporary? So we don't need biometrics to identify the patient, but we can use the unique implant geometry to do that. And the paper that I wrote about that is currently under review. And yeah, it's quite a nice project. And lastly, we don't have to use EMT retrospectively. We can also use it for navigation purposes in the implant procedure. So the group of Christopher Dufell from Mayo Clinic, they use EMT to guide the needles, the needle insertion, especially for cervical and also for prostate brachytherapy. So that brings me to the end of my talk. I tried to give a quick wrap up of what I've done during my PhD, and I hope you find it interesting. I'm happy to answer any questions, and also if anything comes up afterwards, feel free to contact me via LinkedIn or ResearchGate or send me an email. I'm happy to answer them as well.
Great talk. Thank you so much, Christopher. It's very interesting. So we are open for questions. Yes, Amanda?
Yeah, this is really cool. I'm wondering, practically speaking, from a software perspective, I think in like the clinical workflow, this could be really nice to verify just before you deliver the treatment. So do you have a method for maybe like overlaying the kind of reconstructed catheters on, say, just before treatment with the planned catheters so you can compare kind of in real time and just make sure everything is where it's supposed to be?
Exactly. That's what we do. We use a standard registration point set registration method, either coherent point drift or iterative closest point. And then we just calculate the Euclidean distances between corresponding points. So that's very the basis of almost all of the evaluations we did.
And what software are you using for that?
We use MATLAB
Okay.
because that's just our institutional standard, but you could do the same thing obviously in Python or any other
So you're somehow
framework.
taking like if you it's like a like your reconstruction from Oncentra and you're kind of like
Yes.
importing that into MATLAB.
Yeah. So we
Okay.
have the RT plan from the clinical treatment plan,
Hmm.
and then we have a script that extracts those data from the RT plan, and
Hmm.
then we are able to process them in MATLAB.
Gotcha. No, that's really cool. Thanks.
Yeah. Thank you.
And we have a next question from Clara.
Hi, Christopher. Thanks for the talk. That was very interesting. Just a question about, if a clinic wanted to implement this, what is the financial and resource costs for, purchasing the equipment, commissioning, and so forth?
Yeah, that's actually a very good question because that's the most annoying part of that project because Elekta currently is not very keen on continuing the project. As far as I know, they don't see the business case for it. You might imagine that an afterloader, a normal clinical afterloader is, I don't know, like 6-digit numbers, somewhere like €500,000, US dollars, I don't know, around that. But the EMT system would add, I don't know, maybe 100,000 on top of that. And currently they think it's not worth it from a vendor perspective. If you want to buy such a normal EMT system that is not integrated into an afterloader already, I think you end up with like maybe 20, 30, 50,000 maybe, like on that order of magnitude. Does that answer your question?
Yes, thank you. That's
Yeah.
frustrating that they're not pursuing it. Thank you.
Yeah. So in case you ever come across an Elekta booth at whatever conference, just talk to them.
Sounds good.
Thank you. So we have another question in the chat from Sabrina. And she says, thank you for the talk. We are wondering about the precision of the localization. What is the uncertainty on your positions?
Yeah, so the vendor specifications is sub-millimeter, so I think 0.6 millimeters. That's pretty accurate, and we actually we can confirm those values in phantoms. Obviously, in patients, the uncertainties come from anatomical changes, and like in case of breast brachytherapy, we also have breathing motion that we have to compensate for. So we end up with an uncertainty budget of, let's say, 2 to 3 millimeters in patients. But the technology itself is in good environments, it's sub-millimeter. And you have to, the big problem, if you wish, is that fundamentally electromagnetic tracking is susceptible to interferences by magnets, obviously, and also by large ferromagnetic objects. So, for example, CT tables can be a problem if you're too close to them. So yeah, but there's several studies about that, analyzing the effects of equipment that is present in brachytherapy suites about that.
Great, thank you. So is there any other questions? If not, you can always write your questions in the chat. Thank you so much, Christopher.
Well, thank you for having me.
Okay, so next up we have Prarthana Pasricha. Shirzad, would you be able to, or I guess I can just introduce the title of her talk. Yeah, so Prarthana is a PhD candidate at Carleton University, and today her talk is on tiles, targets, and truth, comparing TG43 and model-based dose calculations in brain brachytherapy. Perfect.
Can you guys hear me? Yeah, perfect.
Yeah.
Well, thanks for the introduction. I'll be talking about tiles, targets, and the truth. Sounds a bit dramatic, but it's basically the gamma tile. It's a new brain brachytherapy treatment approved by the FDA 2019. There's clinical trials going in the States, none in Canada yet, but I'll be doing some TG43 versus 186 analysis for these.
Oh, before you start, did you want to put your presentation in?
Oh, the presenter
full,
mode?
yeah, yeah, there we go. Perfect. You can go ahead now.
Perfect. All right. So what is the clinical motivation behind this? We know brain cancers are invasive. For example, the GBM, glioblastoma, after surgery follows 6 weeks of chemo and radiation, follows another 6 months of chemotherapy, just for it to come back with a reoccurrence rate of 80%. Now that's huge, right? Patient has gone through everything and they'll still be susceptible to the tumor coming back. And that's exactly where the gamma tile comes in. The issue right now is, so after the surgery and before the patient can come back and get the radiation therapy, you gotta wait for a week or two for the surrounding tissue to heal. And studies have shown that between that time, by the time the patient comes back, you could already see some of the tumor coming back. And that is exactly where gamma tile is helpful. You remove the tumor and you put the tiles right in the cavity right after the surgery, or actually during the surgery. You took the tumor out, you put this tile in and stitch it up, and it starts to give radiation right at that time. What is the gamma tile? It has 4 cesium-131 seeds, and it's there in a collagen tile. This collagen is reabsorbable, which means it gets slightly, after some time, it would just dissolve in the brain, so you don't really have to worry about it. It's a permanent implant. It's cesium-131. The half-life is 9.8. So again, we don't really have to worry about it. It can easily be a permanent implant. So as a lot of us know, brachytherapy, a lot of decisions have to be made on the spot. With the neurosurgeons, the medical physicists, they have experience about a lot of things, but when it comes to a new technology or a new therapy, the surgeon could be asking the medical physicist, do you think we can fit another tile in here? There seems to be, we might want to put in an extra one here. And he would be asking a medical physicist that, and you need to tell right on spot, what do you think about that? So we use treatment planning systems and computer simulations to come up with an optimized plan. And here's the thing, most clinics in the hospital or the treatment planning system are TG43 based system, which means they assume all the tissue as water, and we do not worry about the bone or the cerebrospinal fluid, which works in most of the cases, but not all. So part one of this work is the dose evaluation of multiple, sorry, what happened here? Of multiple gamma-tile in heterogeneous brain model using X-Brachy. So what do I do in here is we start with some toy model simulations where I have a few tiles in a brain phantom. First of all, I'll consider the brain phantom to just be a TG43 phantom. It's just composed of water, and I do not consider the inter-attenuation effects of the seeds. The second phantom was a brain CSF phantom. So I have the brain parenchyma, and it gets filled with the cerebrospinal fluid. So a model which would be representing a tumor which is deep-seated and not really near the skull, and another phantom where I have the inhomogeneous brain CSF phantom, which also includes the bone and the skin, which is more representative of a case where I have the tumor close to the skull. For the results, I compare the dose to the prescribed area, which is 0.5 centimeters above the surface of the tile. The tile is supposed to give 60 grays at 0.5 centimeter from where it is placed. So I compare the dose to the prescribed area, and then I also compare dose to the inhomogeneities. TG43 does not, is it giving me the right values to what dose am I actually giving to the bone if it's something close to the skull area? Here's a quick representation of my setup. The first phantom, as you would see, is just 3 tiles with 4 seeds each in a 5 by 5 by 5 water phantom, fairly easy. And then you step it off with filling the external part with some brain tissue, brain parenchyma, and I'll fill the insides with the cerebrospinal fluid. And that is what actually the cavity gets filled with after some time once the tumor is removed. And then moving on to a bit more complexity where I add layers of bone and skin. All of this was done in X-Brachy. So point one was to compare the dose to the prescribed area, and point two was to compare dose to the bone and skin. Looking at the results real quick, we see that we observe reduced dose uniformity when we model tissues versus TG43. Also, the prescription dose is up to 4% lower in the brain CSF model. And when I look at the dose of the prescribed area, when I consider all the heterogeneity, so my model number 3, I see differences up to 27%. So it's 27% lower than what you think you're giving, which is not what we would like to do. So as we saw here, the TG43 is underestimating the dose to the heterogeneity. For the dose to the bone area near the brain bone interface, we see the dose is up to 4 to 5 times higher, which means TG43 was actually underestimating it, and it was thinking you're giving close to the bone, but you're actually giving 5 times more dose than what you think you were giving. Similarly, dose to the skin was about 7 times lower, but we're not worried about that. That's actually a good thing. Differences. So these differences are driven by photoelectric effects. This is cesium-131. We're talking about keV energies. We know photoelectric effect is going to be relevant. And as we would see at the interface, the ratio are huge, but as you go far from the interface, it goes low. So that is expected out of it. That was the part one. The quick little TG43 versus 186 comparison. Part two of the study, which is asking a more practical question, was dosimetric impact of source displacement in gamma-tile brachytherapy. So a lot of studies, the clinical studies have shown that after the surgery, tiles can shift, which could lead to seed displacement. So the focus of this particular part was to analyze how much different, if it's getting displaced by a centimeter or less than that, am I looking at huge differences in my dose distribution? Is that something to be worried about? So methods for this simulation, again, I start with, again, these are toy model simulations. I start with 2 gamma tiles in a brain CSF phantom, and then I keep increasing or decreasing the distances between those. I also take in a case for the flip tiles. Now you'd be wondering, why am I really worried about the flip tiles? It's, they're supposed to be stitched. They shouldn't get flipped. But in the clinic, they actually use the flip tile to give more dose than 60 grays. So the way the tile is designed, the seeds are close to one side than the other, which means if I flip it around, I can give more dose than 60 gray, and they've actually done that at the clinic. So I think it would be a useful case to study how much more dose am I giving with that. For the results, I evaluate the tile separation, overlap, and flipped compared to my reference tile simulations where I have everything in the place. So this is my reference simulation, 2 tiles side by side, no overlaps or distancing. And that will be space tiles. I keep on increasing the space by 0.25 centimeter up to 1 centimeter. And that's the case for overlapping tiles. Looking at the results real quick here, we see that the percentage differences in dose increase with the greater intertile separation. So just to give you a quick idea, we're looking at 0.75 centimeters. So if the 2 tiles are getting separated by only 0.75 centimeters, we see hotspots of about 1.5 times the dose, which is huge. So we want to give 60 grays, but now we're giving 60 plus 30. So that's big. It's not very subtle. Similarly, for tile overlap, as expected, we'd see some differences at the central axis. And for the flip tiles, for the overall area, we give the central dose increased by up to 1.5 times, which could be a useful thing to do in the clinic. To conclude, the TG43 overestimate the brain dose coverage. TG186 offers more accurate guidance, especially for post-implant assessment or combining gamma tiles with external beam boost. The source displacement, as we see, less than a few centimeter can really impact the dose distributions. All this is to inform the physicians when they're doing the treatment planning. Things like these can happen, so make sure you have these considerations in mind while you're planning the treatment for using gamma tiles. Next steps, and what I'm doing right now is moving on from these toy model simulations to actual patient data. We have collaborators in Ackerman Cancer Center in Florida who's providing me with clinical patient data, and I can do these comparisons in actual patient data as compared to what I did here for thermal simulations. I'd like to thank my collaborators, Fatime, who's a resident, Nilsson, chief medical physicist, Artemis, who's a lab mate, and my wonderful supervisor, Rowan Thompson. And I'm happy to answer any questions you guys have.
Thank you for the great talk, Prasna. So we'll now open up the floor to some questions. Do we have any questions? And please feel free to put your questions in the chat, or you can also raise your hand and ask as well. I guess I can. Oh, yeah. Go ahead, Clara.
Hi, thank you for the talk. That was very interesting. And excuse my possibly ignorant, naive question, but I'm just curious about, the impact of the brain brachytherapy on these patients. It's not something I'm very familiar with. So maybe if you can give us some more background about that.
Yeah, no, I don't blame you on that. It's fairly new, as I said, approved in 2019. The clinical trials are still going on. We had the results from the initial results from the clinical trials very recently, and they're all there on the Gamma Tile website when I was trying to prepare for these this presentation. And it seems like it does have, well, I can give you, I don't really have the numbers on me, but they compared these treatments to what we have right now, like what we usually do for GBM, the regular standard 6 weeks of chemo and what was it? Yeah, 6 weeks, right? Yeah, 6 weeks of chemo and radiation followed by 6 months of chemo. So that is the standard that we've been following. And they compared it to this, and it is giving better results. But again, I think it's way too soon in terms of saying in terms of survival. Like we still would need to wait another 5 or 10 years to give, does that improve the survival? Sure, it improved the radiation necrosis. That was one big use of it. It reduced the radiation necrosis, but what about the survivals? I think that's a bit too early to say for that right now.
Thank you. Thanks.
Yeah, I can ask a question. Do you see any like key challenges in pushing this framework toward even like lower doses or even like smaller target volumes?
You mean using the gamma tile for a smaller target or
Yeah.
um so I mean you take on how many tiles you want. So you can order 10 tiles. If you look at the cavity, there's a formula we use and you come up with, okay, we will be using 10 tiles for this particular patient. So I'm not like you can use, if it's a smaller cavity, we'll probably end up using a small number of tiles. In some of the clinical cases, they've actually split the tiles into halves and use half a tile sometimes. So they'll end up using 4.5 tiles instead of 5 tiles. So that's doable because it's college and you can just cut it off. So I guess that would help in using this particular product for a smaller cavity or a smaller area.
Okay. Oh, yeah, and Shirzad, go ahead.
Yeah, thank you for the talk. Just a quick question. If the X-brachy was benchmarked for this gamma tile dosimetry?
So X-brachy has been used for a lot of other brachytherapy treatments, and it is one use of this is X-brachy is made for brachytherapy simulation. So I mean, there's no benchmarking in terms of the product itself, but yeah, we start with using a cesium 131C. So that's what I begin with. I look at the dose distribution using just one cesium 131C, and then I try to benchmark, is it similar to what I see from results in the literature? So yeah, benchmark in that sense. I do start up with one tile, like one seed simulation, and benchmark it, to the other results. But in terms of the full product, here's the thing: since it's fairly new, we barely have any data in terms of Monte Carlo simulations. And that was one motive for me to get on it. This is not my main thesis, but like a side project for me. But as I said, there's barely any simulation or Monte Carlo data on it, so we thought it would be useful to actually compare and have the Monte Carlo results for these.
Okay, great. Thank you.
All right, thank you, Prarthana, for your great talk. And then now, next up, we have our last speaker of the day, who is Ruiyan. She is a PhD candidate at the University of Toronto, and today she'll be giving a talk on the automatic contouring for MR-guided cervical brachytherapy.
Okay. Thanks for the introduction, and thank you for having me here today. Can you see my screen and the pointer? Yeah, okay. So yeah, I'll just jump right in. Cervical cancer is the fourth most common cancer in women worldwide, and in 2024, there are 400 deaths in Canada because of this cancer. And currently, cervical cancer is actually the fast increasing cancer in females, with the incidence rate increasing 3.7% per year. So the standard of care treatment for cervical cancer include the external beam radiotherapy plus chemotherapy plus the brachytherapy. So in the study on the right showing that patients treated with brachytherapy actually had a significantly higher overall survival rate compared to those who didn't have brachytherapy. And so this is the MR-guided brachytherapy workflow at our hospital, Princess Margaret Cancer Center, the entire procedure time is about 3 hours and 42 minutes, which is pretty long. And on the day of brachytherapy, the patient is first brought to the treatment room and put under anesthesia, followed by the placement of applicators and catheters, and then the post-implant imaging, MR imaging will be taken, followed by the contouring, applicator needle reconstruction, and registration. And then the treatment plan will be developed, followed by the quality assurance, and finally the patients will be treated. And so during the entire process, these 3 steps alone takes about 1 hour and 27 minutes. And since they're all computational work, there are huge potentials to automate them with artificial intelligence. And in this study, my project is mainly focusing on one of the most time-consuming steps, which is the contouring. So the contour for MR-guided brachytherapy in cervical cancer has 2 major groups. The first is the organ at risk, and second is the radiotherapy target. So there are 3 targets we need to segment in total, and in this study, we are mainly focusing on the second one, the high-risk clinical tumor volume, which is the red contour you can see in this figure that includes the residual GTV plus cervix plus MR aggression. There are clinical considerations specifically for MR-guided cervical brachytherapy that the clinicians usually take into consideration in the clinical workflow, and we also want our deep learning model to consider that to make sure we have a clinically acceptable contour. So for OER segmentation, you can see this is a sagittal view figure, and the tumor is in the middle of the slice. So because radiotherapy target is inserted in the tumor, the OER dosimetry is only calculated coming from the part of the OER that is close to the target or the tumor, which you can see here is the color region on each OER. So this requires a highly accurate contour in this part of the OER for human experts, and we also want to mimic this in our deep learning algorithm. And on the other hand, for target segmentation, it is a much more complicated clinical decision-making process. And as mentioned in the ICIU report 89, the target selection should be based on both the MRI and also the clinical examination information, which we also want our deep learning model to have access to. So first, I'll start with the near-to-target OER segmentation project. This is our proposed method. During model training, we have a standard 3D UNet as the model architecture, and we propose a novel distance penalized loss function that compares the errors between the model prediction and the clinical ground truth. And in that way, they can iterate multiple times during the training so that we can guide the model's attention towards to the near to target region and give the high accurate contour on that region. To develop this loss function, we first start with the ground truth high-risk CTV contour, and then we calculate the distance between each voxels to the nearest high-risk CTV point, as you can see here. And then we use the inverse square law to generate the distance penalty for each voxels, so that the closer the voxel is to the target, the higher penalty it will be given to them. So this is the training part, and now moving forward to the evaluation part. We proposed a novel geometric evaluation metric called the weighted dice similarity coefficient, the weighted DSC. You can see here, the mechanism is pretty simple. It is like the closer the region is to the target, the more penalty will be given if there's any mismatch between the ground truth OER contour and the model predicted contour. Also, this is a directly reflect of whether our distance penalized loss function can have the effect. Followed by that, we also performed a dosimetric analysis. First, we apply the clinical plan to our auto contour and calculate the dose volume histogram. And then we calculate the absolute dose difference between the auto contour DVH values and the clinical DVH values to make sure to use this as an indicator for how accurate our auto contour is in terms of dosimetry. We also conducted the clinical acceptability test. So here, sorry, the first question we want to answer is whether our novel geometric metrics can actually be an indicator for the dose accuracy, because our weighted DSC already taken consideration of the close to target region. So our result shows that there's a comparison between the weighted DSA we proposed and also the volumetric DSA, which is a standard geometric matrix, which hasn't have any penalty associated with it. So you can see here our proposed loss dice score had a stronger correlation with the OER dosimetry accuracy compared to the standard metric. We had a moderate correlation with the absolute D2CC difference versus the standard model. The standard dice only have a no to weak correlation with the OER dosimetry. So moving forward, we also want to see if our distance penalized loss function have the effect is supposed to be. So geometrically, we calculated the weighted DSA for 4 of our OERs. The green boxes you can see is our distance penalized loss function. It has improvement for all the 4 organs compared to the baseline loss, and it has a statistical significant improvement in terms of the small bowel. The similar trend can also be demonstrated in the dosimetric result. The closer to 0, meaning that they have like better dosimetry accuracy. And you can see our green boxes, the proposed loss function, always have smaller dose difference compared to the baseline loss. And again, the statistical significant improvement is observed in the small bowel. So the second project is about the clinical examination-based high-risk CTV segmentation. So as I mentioned before, clinical examination is important to be included in target delineation. And during brachytherapy, an intraoperative gynecological examination is performed after patient is put under anesthesia and before the catheter insertions. So during that examination, oncologists will dictate any clinical findings and abnormalities into operative notes, and which they will further refer to when they do the contour of target. And in our model, we utilize a large language model called Llama 3, and we give a prompt to the model saying that please summarize one sentence for the vaginal involvement information from the clinical notes, and then we copy and paste original clinical notes to the model. The model output is the summarized vaginal involvement information. So the reason we are in particular interested in vaginal involvement information here is because superficial vaginal involvement can be very hard to visualize on MR image alone because of the MR resolution. And also it's very important to adequately treat the vaginal involvement because it can further lead to local recurrence, which can be very hard to deal with later if we are not adequately treating them. So the Llama 3 output is still text, and in order for the model to understand this information, we need to further embed them into numerical representations using a BABMAT-BERT as an embedding model. And furthermore, we incorporate the numerical representation into the decoder part of our image segmentation model, which again is a 3D unit here. And as a comparison, we also trained a vision-only model, which only consists of the image segmentation pipeline without any clinical notes information. In terms of the results, geometrically, because the only information, the difference between the multi-model and the vision-only model is whether we're giving them the vaginal involvement information or not. So geometrically, we want to only look at the part of the high-risk CTV that is within the vagina. And then we calculate the volumetric conformity index between the ground truth and prediction. So our result shows that the multimodal method we proposed is giving a statistically significantly improvement in terms of the VCI with the mean value of 0.62 versus the vision-only model is 0.57. Dosimetric analysis also showing the same trend. So here is the D90 UD2 difference with a clinical plan implemented a clinical plan applied to the auto contour, the closer to 0, meaning that they have a better dose accuracy. And you can see our multimodal contour also have a smaller difference with the clinical value in terms of the D90, E2, D2. And here are 2 illustration examples. The first cases you can see on this slice, the vision-only model failed to pick up the high-risk CTV contour on this slice versus our multimodal contour successfully identified the high-risk CTV. And for the second slide, you can see the vision-only contour missing part of the contour on this slice versus our multimodal contour model correctly picked up the entire high-risk CTV segmentation just as the clinical ground truth. So to sum up, in this study, we developed a deep learning-based auto-segmentation models using our institutional MR-guided radiotherapy, MR-guided brachytherapy data, and with consideration of clinical criteria to improve the contour efficiency and accuracy. We first proposed a near-to-target OER segmentation, incorporated the dosimetric consideration into OER delineation, and along with novel evaluation metrics to better correlate the geometric performance to dosimetric accuracy. And for high-risk CTV, we integrate the vaginal involvement information from clinical notes to significantly improve high-risk CTV segmentation accuracy. And moving forward, we are now currently extending the segmentation model to include the other 2 targets in cervical brachytherapy. And in parallel, we are also conducting prospective evaluation serialization at our hospital. And then moving forward, we want to perform the external validation with other Canadian institutions. And ultimately, we want to deploy our model for clinical use. And with that, thank you for listening, and I'm happy to answer any questions.
Okay, yeah, thank you for that great talk. We already have a question in the chat. So it says, thank you for the presentation. I have 2 questions concerning the first part of your presentation. What motivates the use of a 3D UNet instead of a SWIN UNet R, for example, small number of ground truth? And have you considered using boundary accuracy metrics?
Yeah, that's a good question. Thank you. So for the first question, I think 3D UNet, so is still the standard, like the state of the art, like the standard architecture for medical image segmentation, like 3D medical segmentation. And to give you a more detail, the network we are using is based on the NUNet framework. We're just customizing the NUNet pipeline to integrate our unique considerations. And in terms of the SWAN UNet R, so first, I think my understanding is the transformer-based model needs a more it needs a more image, and because we have very limited data in the brachy field, like our model is trained with around 200 patients, which is about 800 scans, but it's still, I think, it's considered relatively small for the transformer-based model because it requires a much more like parameters in the model, so it's easier to overfitting and have other issues. And another thing is that yeah, that's the main reason why we are still sticking with the 3D UNet. And second question, in terms of the boundary accuracy matrix, that's the reason why we are developing a distance penalized loss function instead of a boundary aware matrix. Because in brachytherapy, as I mentioned, the OAR dosimetry is coming from the inside part of the organs instead of the boundary. Like in external beam, I knew that the boundary is very important because the radiation coming from the outside of the patient. But for brachytherapy specifically, especially for example in prostate, they only segment part. They don't even contour all the way up to the small bowel or the rectum all the way down, because the dosimetry, the only part that contributes to the dosimetry of OAR calculation is the part of the organ that is close to the target. That is the reason why we only considering that part over the entire boundary accuracy matrix.
Okay, and I just had one question because you said that like your future work plans to evaluate the models across institutions. So I was thinking what your thoughts would be on how well this approach might be generalized across different institutions and like variation, like just and like how it's gonna vary from clinic to clinic and
Yeah.
such.
Yeah, that's a good question. Actually, yeah, that's a very important question because our model is like supervised model based model. So, ideally, our model will be only will have its like optimized performance only with our like all in distribution data, which is the data trained at our hospital. So, if we want to validate the model in other institutions, they will definitely have some performance shift because their data is considered like out of distribution, like especially if they are using different protocols, different scanners. And we have conducted like a kind of simulation scan on this a study on this problem because our center have multiple scanners and multiple applicators. So we test our model trained with one type of scanners and applicators and test them on the other types. And we do see there's a performance dropout, like performance decrease. But we also demonstrate that with a very small set of fine-tuning cases, we can fine-tune the model and make the model regain its generalizability. So this is also the current the plan if we want to use the model in other institutions like Sunnybrook or McGill. We need them to have kind of GPU equipped local computers so that they can conduct their own fine-tuning using their institutional data based on our like pre-trained model base.
Okay, yeah. Okay, thank you. So right, that brings us to the end of our second research and discovery seminar series. And before we wrap up, I would like to briefly highlight what's coming up next from the Comp Student Council. So in February, we'll be hosting the Comp Career Catalyst that's focused on treatment planning showcase with Ethos and MR Linac. And this session will be highlighting emerging planning workflows as well as clinical perspectives. And then in March, we'll have our third research discovery session, which will focus on the frontiers in radiation therapy with an emphasis on proton therapy and flash. So I hope you'll enjoy us for both of these upcoming sessions. And you can also use the QR code here to tell us about your research or stay connected with the Comp Student Council updates. And then in addition to the student council programming, I would also like to highlight sessions organized by the Comp Residence Subcommittee. So this is an early career seminar series focused on navigating professional certificate in medical physics with perspectives across nuclear medicine, radiation oncology, as well as in diagnostic imaging. So this session will be particularly valuable for trainees or early career physicists who are planning for their certification pathways. And then finally, I would like to draw our attention to our upcoming collaborative session between the Comp Student Council and the CW Women's Committee IDEA. So the session will be focusing on how to get involved with Comp and the broader medical physics initiatives, featuring speakers from the Student Council as well as the CWC IDEA Committee. And will take place on February 9th and is a great opportunity for students and trainees who are interested in like leadership, service, as well as and community engagement within comp. And I've also put the link to register for the session in the chat there. So finally, thank you for joining us today, and we look forward to seeing many of you at our like future comp student council as well as committee events. Thank you. And thank you to our speakers who are here to give us a great talk and about the research that they're conducting.